So let us next discuss sexually transmitted infections. If you recall, while discussing viral infection, we have already discussed few sexually transmitted infections. So few viral STIs are anogenital warts, genital molluscum contagiosum, and herpes genitalis. So we have already written various important points regarding these three viral STIs in the viral infection. Let us discuss other sexually transmitted infections, like fourth one is syphilis. Now we will be discussing various differentiating features between these sexually transmitted infections like syphilis, LGV, lymphogranuloma venerum. So LGV, lymphogranuloma venerum, chancroid, and donovenosis. Okay, so we are going to discuss these four conditions together. All are sexually transmitted infections: syphilis, LGV, that is lymphogranuloma venerum, chancroid, and donovenosis. Donovenosis is also known as granuloma inguinale or granuloma venerum. So another name for donovenosis is granuloma inguinale or granuloma venerum. Now these are few differentiating features, like first one is causative agent. Now all of you know causative agent for syphilis is Treponema pallidum, while LGV is caused by chlamydia trachomatis. There are various serovars like L1, L2, L3. If they ask you which among these is most common, then it is L2. Then chancroid is caused by Haemophilus ducrei, and donovenosis is caused by Klebsiella granulomatis. The old name of this bacteria was Chlamytobacterium granulomatis. So Chlamytobacterium granulomatis, now known as Klebsiella granulomatis. The next differentiating feature is incubation period. Now incubation period of syphilis is 9 to 90 days. For LGV it is 3 to 30 days. 2 to 5 days in chancroid, and 8 to 80 days in cases of donovenosis. Now this is very long in cases of donovenosis. Sometimes it can be as long as 1 year, 365 days. Now the next differentiating feature is clinical features. Now we all know that clinically these patients can present with genital ulcers. So if we talk about primary syphilis which present with genital ulcers, so if you examine these genital ulcers of syphilis, you will find their number is generally single. Similarly, in LGV, the lesions are generally single, while they are multiple in chancroid and single in donovenosis. Now, the second characteristic of the genital ulcer of syphilis is, on palpation, look for any tenderness or pain. So these are painless. This is also painless. This is painful, while this is also painless. If you examine the base, you will find it is clean or clear base, which is non-vascular. Similarly here, the base is non-vascular, while here the base is granulomatous. which may bleed on touch. But remember, the base of donovenosus ulcer is very characteristic. It is beefy red, which bleeds very easily on touch. Which bleeds very easily on touch. If you look at the edges or margins, here they are elevated. They might be elevated here as well. But the characteristic margins or the edges which are seen in chancroid are undermined. Undermined. They might be elevated here as well. And the last one is induration. So when you are palpating this syphilitic ulcer, you will find it is very firm, hard, button-like. So button-like firm induration is seen, and that is the reason why it is known as hard chancre. So syphilitic chancre is hard chancre, while it is firm here. Induration is absent here, and that is the reason why this is known as soft chancre, while it is firm here. It might be variable in donovenosus. So these are few features of the genital ulcers in these different conditions, and some of them are very important, like if it is written multiple painful genital ulcer with undermined edges, okay, this is very characteristic of chancroid. Similarly, if it is written that painless beefy red base which bleeds very easily on touch, then probably the examiner is talking about donovenosus. Similarly, if they mention that single painless firm or hard chancre is seen, then it is probably syphilis. And similarly, in LGV, you can note down one more point, that these genital ulcers are transient. Transient, that is, they last for a very short duration. Okay, so this is important clue towards LGV. They are transient. Okay, so by the time the patient present, most of them might have healed. Now, along with genital ulcer, you should also look for lymphadenopathy. So if you are examining inguinal lymph nodes, you will find in syphilis they are generally bilateral and non-tender. So bilateral non-tender lymphadenopathy is seen, and this is rubbery in consistency, also known as shotty. So if rubbery or shotty lymphadenopathy is mentioned, that means the examiner is talking about syphilis. While it is unilateral and tender in cases of LGV, it is unilateral and tender in cases of chancroid, while no lymphadenopathy is seen in donovenosus. Instead, what happens, sometimes inguinal nodules are present, and these inguinal nodules, they look like lymph nodes. So that's why these are also referred to as pseudo buboes. So pseudo buboes are seen. This is again very important, pseudo buboes. So if rubbery and shotty lymphadenopathy is seen, then it is probably syphilis. And if pseudo buboes are seen, that is, what are pseudo buboes? You can note down, these are subcutaneous nodules. So these are subcutaneous nodules in inguinal area. So these are subcutaneous nodules in inguinal area seen in cases of donovenosus. Okay, so these are inflammatory nodules, these are subcutaneous nodules, and these are not lymph nodes. But since they are present in inguinal area, sometimes they resemble lymph nodes, and that's why these are known as pseudobuboes or false lymph nodes. Now, as I told you that the genital ulcer of LGV is transient. So many a times by the time the patient presents, most of these genital ulcers have healed. So either the patient presents initially with genital ulcer, or later on patient presents with lymphadenopathy. So lymphadenopathy, whenever seen in LGV, is generally without concomitant genital ulcer. So if you find this lymphadenopathy, you will find this unilateral tender lymphadenopathy without concomitant genital ulcer. While here, these buboes, the term buboes is used when there is suppurative lymphadenopathy. So generally this is suppurative lymphadenopathy, and this is generally along with concomitant genital ulcer. So if unilateral tender lymphadenopathy without concomitant genital ulcer is present, then this is suggestive of LGV. And if these buboes or unilateral lymphadenopathy is present along with genital ulcers, then it is suggestive of chancroid. So other features along with lymphadenopathy is also important clue in the question. Next is investigation. Now here we are dealing with primary syphilis, that is the syphilis which present with genital ulcer. So here the best is dark ground microscopy. So investigation of choice for primary syphilis is dark ground microscopy. Okay, while the investigation which is preferred in cases of LGV is nucleic acid amplification test. So here nucleic acid amplification test is done. While in Haemophilus ducrei, which causes chancroid, when you prepare smear and do gram staining, you will find this gram negative cocci giving school of fish or railroad track appearance. So this is the characteristic appearance, and why this appearance is seen, because these bacteria, they are present in parallel rows or chains, and since they are present in parallel rows and chains, it look like school of fish or railroad track appearance. Okay. Similarly here, because this is donovenosis, here which bodies are seen? Donovan bodies. Donovan bodies, and the characteristic feature of Donovan bodies is their shape, that is they appear something like this. Because of the bipolar staining, they give resemblance to closed safety pin. So you will get closed safety pin appearance. So closed safety pin appearance is seen. Now these are the various investigations which can be done, but remember there are two obsolete investigations which are no longer used, but they were used in past, and sometimes they ask you the question on that. Okay, so just remember their names: free test and ITO test. Free test is done in LGV, ITO test is done in chancroid. Both these were intradermal test which were used in past. They are obsolete now. So these were intradermal tests which were used in past, but still sometimes they ask you that free test is used in or ITO test is done in. So remember, free test is for LGV and ITO test is for chancroid. These are obsolete tests. Next is treatment. Okay, so the drug of choice for primary syphilis is benzathine penicillin. So all of you know that we treat syphilis patient with benzathine penicillin, and all the different types of syphilis, like if the patient do not take treatment during primary syphilis, it might land into secondary syphilis or latent syphilis or tertiary syphilis. So in various types of syphilis, which we will be discussing later, in various types of syphilis, the drug of choice is benzathine penicillin. Okay, but except for one type. So benzathine penicillin is the drug of choice for syphilis in all the types except for neurosyphilis. Now why this is not used in neurosyphilis? Because this drug do not cross blood-brain barrier. So that's why in neurosyphilis it is not effective, and in neurosyphilis the drug of choice is aqueous or crystalline penicillin. So aqueous or crystalline penicillin is the drug of choice in neurosyphilis. In rest of the syphilis we give benzathine penicillin. While here the doxycycline is the drug of choice, here azithromycin is the drug of choice, while in donovenosis also azithromycin is the drug of choice. Now always remember that whenever you are giving penicillin to any patient, first do sensitivity testing. Okay, so many a times these patients, they come out positive or they are sensitive to penicillin. Okay, so if the patient comes out positive for sensitivity testing, then you should not use penicillin, and in such cases what you should give? So the second choice becomes, so if the patient is sensitive to penicillin, then second choice is doxycycline. Now we know that doxycycline is contraindicated in pregnancy. So if your sensitive patient is non-pregnant, so patient is sensitive to penicillin and it is non-pregnant, then we give doxycycline. But if your sensitive patient is pregnant, then you can do desensitization. Desensitization. Now because here not only the patient but the patient is pregnant, so patient child have chances to develop congenital syphilis. So we need to give the best drug, and the best drug is penicillin, but the patient is sensitive to penicillin. So what to do? You can try for desensitization, that is gradually the increased dose is given. We start with a very low dose and gradually the increased dose is given so that the patient develops tolerance till the patient can tolerate the full dose. Okay, so desensitization can be tried, but if it is not possible, then erythromycin can be used in the treatment. Now similarly, if the patient is sensitive to doxycycline or the doxycycline cannot be used in a case of LGV, then second choice here becomes azithromycin. While in cases of chancroid, if azithromycin cannot be used, then second choice become cephalosporins like ceftriaxone. And here in donovenosis, the second choice becomes doxycycline. So these are various drugs which can be used in the treatment of these patients. Now let us write down few important facts here. I told you that the genital ulcer of LGV is transient. So many a times patient do not present initially, and by the time the patient presents, these lesions might have healed. So the patient has not taken treatment and the lesion, that is the genital ulcer, have healed. So what happens? They might present with late complications. So that's why the questions are generally asked on the late complications of LGV. So these are the late complications of LGV, which includes genital elephantiasis, groove sign, sometimes also referred to as groove sign of Greenbelt, anorectal syndrome, vaginorectal syndrome. So these are certain late complications of these LGV patients. Now among them, these two are important, and sometimes already questions have been asked, so they ask you questions on these two. So remember, this is a patient suffering from LGV, lymphogranuloma venerum, and sometimes what happens that these lymph nodes which enlarge, they enlarge on either side of the inguinal ligament. So let us consider this is the inguinal ligament, and on either side of the inguinal ligament the lymph nodes are enlarged. So due to this enlargement of lymph node on either side, a groove is seen in between. So this groove which is seen in between is known as groove sign. So groove sign is seen in LGV. Similarly, what happens that later lymphatic obstruction occur, and due to which the size of genital keep on increasing, and when the size of genital increases, what happens later on, vascular compromise can occur, which can lead to gangrene or eating away of the genitals. So in females, when vulval elephantiasis occurs, patient can develop estheomin. Estheomin term means eating away. Okay, so this is known as eating away of genitals or estheomin. Similarly, in males, penile elephantiasis may occur. So when penile involvement occurs, what happens? The size of penis increases and it appears something like this. That is, it looks like a saxophone. So this is known as saxophone penis. So these are two more terms which you can remember, saxophone penis and estheomin. These are also what? These are late complications of LGV due to genital elephantiasis. Now I told you donovenosis presents with painless genital ulcer which is having beefy red granulomatous base which bleeds very easily on touch. Okay, so here ulcer with granulomatous base is seen. So this is known as ulcerogranulomatous type. So the type which we have discussed is known as ulcerogranulomatous, and this is the most common type. As I told you here, ulcer with beefy red granulomatous base is seen. So this is the most common type of donovenosis, but there are few other types also. You can just remember their names, like hypertrophic. In hypertrophic variant, a growth is seen which appear like walnut. So walnut like growth. There are two rarer variants, like sometimes that is necrosis occurs or sclerosis occurs. So these are known as necrotic or sclerotic variant. So these are four different types of donovenosis. You can just remember their names, and remember the most common type is the one which we have discussed, which present with beefy red base, and that is known as ulcerogranulomatous, because ulcer with granulomatous base is seen. Now I told you that syphilis can be of various types. The type which we have discussed is primary syphilis, which present with genital ulcer. Okay, so the one which we have discussed just now is primary syphilis. So whenever the patient is suffering from sexually transmitted infection, because these are sexually transmitted, there will be a history of contact. So always patient present with history of contact. They might sometimes hide this history, but there is always a history of contact which is present. Okay, so history of contact is present, and because there is an incubation period of 9 to 90 days in syphilis, so what happens within this period of 9 to 90 days, patient will develop genital ulcer. So this genital ulcer which develops initially is known as primary syphilis. So how primary syphilis develops? So if we look at the clinical features, you will find that within a period of 9 to 90 days after the history of contact, patient presents with this single, we have already written this point, single painless genital ulcer with clean base and rubbery or shorty lymphadenopathy. Okay, so this is the common presentation, and obviously remember that the base is hard, so firmly indurated, so such type of genital ulcer is seen. If you want to confirm your diagnosis, the investigation of choice is dark ground microscopy. That is, you can examine for these Treponema pallidum which have corkscrew shape and spiral movement, and under dark ground microscopy. And the drug of choice is, I told you, benzathine penicillin. So this is how you are going to approach to this case. Now let us consider that patient develops this genital ulcer, and because this is a stigma in the mind of the patient that he is having this sexually transmitted infection, so many a times they do not consult any dermatologist or they do not visit any medical college. So what happens later on, this genital ulcer might heal. Okay, now when this genital ulcer heal, then the patient may develop secondary syphilis. So when after genital ulcer, the second presentation can be in the form of secondary syphilis. So if the patient is not taking treatment, patient might present with secondary syphilis. Now how these patients present? Secondary syphilis present with very characteristic lesions. They might be in the form of condyloma lata. Now remember this point, condyloma acuminata is anogenital warts. Condyloma lata are lesions of secondary syphilis, and these are highly infectious. So these are highly infectious lesions of secondary syphilis. So patient might present with condyloma lata. Now this term lata, if you know, acuminata means pointed. So there the lesions are pointed. Lata means broad base. So these are broad lesions. So these are broad lesions, and they are usually present over moist areas like groin. Okay, so around genital areas, around anal areas, you might get these broad base lesions which are known as condyloma lata. I will show you the images also. So these are the highly infectious lesions of secondary syphilis. These patients may develop alopecia, which is non-scarring type of alopecia. So non-scarring alopecia. There is a characteristic appearance, and due to which it is known as moth-eaten alopecia. So this is a semi-baldness. At places this alopecia is present. This is known as moth-eaten alopecia. This is the non-scarring alopecia of secondary syphilis. Now if we talk about the skin lesions, these rashes which are seen, they can be of two types. First, they can be pigmented rashes. These pigmented rashes generally develop over palm and sole. Then they might be scaly rashes. These scaly rashes, they are known as psoriasiform. Because in psoriasis, the lesions are erythematous and they have scaling over them, and so are these lesions. Okay, so these are erythematous and they have scaling over them. So because these are scaly lesions, sometimes they resemble scaly conditions like psoriasis. So they are also known as psoriasiform lesions. Okay, there might be other lesions also like annular lesions. So different types of lesions can be seen in secondary syphilis, and that is the reason why it is known as great imitator. It might imitate so many diseases, like because it is pigmented, can present with pigmented lesions, so it might resemble pigmentary condition. It might present with scaly lesions, so it might present with conditions resembling psoriasis or pityriasis, rosea. So that is a differential diagnosis for secondary syphilis. And similarly annular lesions, so sometimes it might mimic tinea lesions, which are annular lesions. So that's why this is known as a great imitator, and this is a differential diagnosis for so many conditions. Okay, but there is one lesion which is not seen in secondary syphilis. Except for this lesion, all different types of lesions can be seen, and that lesion is vesicobullous. So remember, different types of lesions can be seen in secondary syphilis except for vesicobullous lesions, and that is the reason why this is known as great imitator. So this is a great imitator. It can imitate so many diseases and few important diseases. Remember, this is considered as a differential diagnosis for pityriasis, rosea, psoriasis. Okay, so this is a great imitator. Now, one important point to remember here is that this pigmented lesion, which is present over palm and sole of secondary syphilis, when pressed with a awl pin, that is, if you take the head end of the awl pin and press it, so from the blunt end, if you press it, you will find deep dermal tenderness, and this is due to vasculitis. So this is given a name, and this is known as Buschke-Ollendorff sign. Okay, so these pigmented lesions of secondary syphilis, which are present over palm and sole, when you press them with blunt object like pinhead, you will find deep dermal tenderness known as Buschke-Ollendorff sign. Already question have been asked. So this is known as Buschke-Ollendorff sign. Investigation of choice here is non-treponemal test like VDRL, RPR, and the drug of choice here is also benzathine penicillin. Now still the patient has not come for treatment, then patient might develop latent syphilis. So after secondary syphilis, this is third type, that is, so first was primary, second was secondary, then third is latent syphilis. This depending on the duration, which is 2 years. If patient presents within 2 years, early latent syphilis, and if it is diagnosed later after 2 years, then it is known as late latent syphilis. Now the characteristic feature about latent syphilis is that here it is latent, so clinical features are absent. But if serology is done, so serological tests, they come out positive. So clinical features are absent, but serological tests come out positive, and this is latent syphilis. Here the investigation of choice is enzyme immunoassay. So enzyme immunoassay. Now if we talk about the drug of choice, remember here also drug of choice is benzathine penicillin, but one point which you need to remember is that this dose of benzathine penicillin might vary depending on early phase and the late phase of latent syphilis. Okay, so broadly you can divide syphilis into two categories. One is early syphilis and other one is late syphilis. Early syphilis means patient presents early, like primary syphilis, secondary syphilis, early latent syphilis, while late syphilis is late latent syphilis, and sometimes patient develop tertiary syphilis, so these are late syphilis. So if the patient present early and late, the doses are different. So drug of choice is same, that is benzathine penicillin for both. So here also we give benzathine penicillin, here also we give benzathine penicillin. Now what is the difference? Normally how benzathine penicillin is given, this is an injectable drug and it is given deep intramuscular injection. The dose is 2.4 million unit, and this dose of 2.4 million unit is divided into two and given in both the buttocks simultaneously by deep intramuscular injection. So on the same sitting we do it. What we do, 1.2 million unit in each buttock by deep intramuscular injection. So this is the treatment, that is 2.4 million unit deep intramuscular injection, 1.2 million unit in each buttock. So this is the dose for early syphilis, that is primary syphilis, secondary syphilis, early latent syphilis. But in late latent syphilis and in tertiary syphilis, again what we do, we give the injection by deep intramuscular injection. The dose is same, that is 1.2 million unit in each buttock, but every week. So for 3 consecutive weeks, that is 3 doses are given. So if 3 doses are given, the total dose becomes how much? 7.2 million unit. So this is the difference. Okay, so in both we are doing the same thing. We are giving benzathine penicillin 1.2 million unit in each buttock, deep intramuscular injection, but here only one time, here 3 times. So here total dose is 2.4 million unit, here total dose is 7.2 million unit. Okay, now still the patient is not diagnosed during the latent phase also, then patient can develop tertiary syphilis. Tertiary syphilis. Now tertiary syphilis can present in various forms, like presents with gummatous lesion, may present with CVS involvement, may present with CNS involvement, that is neurosyphilis. Now what are gummatous lesions? Gummatous lesions are generally present over skin or mucosa, and they are rubbery nodules which may ulcerate, and this ulcer have punched out edges. So with punched out edges and washed leather base. So remember, punched out edges with washed leather base is the characteristic finding of these ulcerated nodules, which are the gummatous lesions. When CVS involvement occurs in syphilis, that is tertiary syphilis, what happens? Generally ascending aorta is involved, and in this ascending aorta you will get aneurysm. Then there is valvular heart disease in the form of aortic regurgitation. So these are the common presentation, that is aneurysm in ascending aorta and aortic regurgitation. Similarly, CNS involvement occurs, and then the patient present with general paresis of insane. That is, patient is going insane, patient is developing psychiatric abnormalities, and also patient develops stapes dorsalis. You might have read in medicine stapes dorsalis, that is patient develops gait abnormalities. So once this question was asked, that patient had a history of contact many years back. Okay, so many years back, and now developing gait abnormality along with psychiatric abnormality. So diagnosis is neurosyphilis, that is involvement of CNS have occurred. Now when the patient is suffering from neurosyphilis, the investigation of choice is CSF VDRL, and here you should look for CSF pleocytosis, and this pleocytosis responds to treatment. Okay, so this corresponds to treatment. Drug of choice I already told you, this is a tertiary syphilis, so the treatment will be benzathine penicillin, but that of late type, that is 3 doses are given, 7.2 million unit. Now if the patient suffering from syphilis give birth to a child, that child can develop congenital syphilis, and this congenital syphilis, again depending on the duration, which is 2 years, can be labeled as early congenital syphilis and late congenital syphilis. So if the patient presents early, the presentation can be in the form of vesicobullous lesions. And as you all know that I told you that in secondary syphilis, all the different types of lesions can be seen except for vesicobullous lesions. So remember, if in a case of syphilis, vesicobullous lesions are seen, then the examiner is talking about which type of syphilis? Yes, early congenital syphilis. So this is the only type of syphilis where vesicobullous lesions are seen. These patients can present with nasal snuffles, which is rhinitis. Late congenital syphilis can present with Hutchinson triad. This triad is very simple to remember. You just need to remember 3 monkeys of Gandhi ji. Bura mat dekho, bura mat bolo, bura mat suno. Okay, so 3 things. One finding related to eye, one finding related to mouth, and one finding related to ear. Let us write down these findings. So 8th nerve deafness. ये पेशेंट बुरा नहीं सुनते क्योंकि डेफ है. ओके, सो दे आर सफरिंग फ्रॉम 8th nerve deafness. So one finding related to ear. Interstitial keratitis, इनको साफ नहीं दिखता क्योंकि आंखें खराब है. Okay, so interstitial keratitis, one finding related to eye. And Hutchinson teeth, बुरा मत बोलो क्योंकि दांत खराब है. Okay, so teeth involvement, that is Hutchinson teeth. Now they might ask you that what is Hutchinson teeth. So remember, these are central upper incisors. So these are what? These are central upper incisors with notch. So if this is the teeth, you will find a notch here, and they are appearing like a barrel or a peg shaped. So these are peg or barrel shaped teeth. Okay. Now there are various other findings also in late congenital syphilis, like frontal bossing might occur, severe tibia can occur. So these are other findings, but at least remember this Hutchinson triad. So these are the findings which you need to remember. Next we will be discussing urethral discharge. See, in patients who are suffering from STI, many times we give syndromic management, and one of the STI syndrome is urethral discharge syndrome. Okay, so sometimes what happens, that patient presents with a symptom, and at the periphery, if you are unable to diagnose these cases because of lack of investigation, so what you can do, you can give a syndromic management. Okay, so like urethral discharge can be caused by various conditions, and if you are unable to diagnose those conditions or those diseases specifically, simply what you can do, you can give all the drugs which can take care of all those conditions which can cause urethral discharge, and you will be able to treat urethral discharge. So due to lack of specialist at the peripheral health center, due to lack of facilities available there, or lack of investigation, what happens, the government of India have provided these NACO kits, that is National Air Control Organization kits. These are also known as STI kits, and these kits are used for the treatment of these syndromes, and this treatment is known as syndromic management. So we'll be discussing syndromic management in detail, and one of the syndrome is urethral discharge. If you recall, in fungal infection I already discussed about another syndromic management of vaginal discharge, that is the vaginal discharge syndrome. Now we are discussing urethral discharge syndrome. Okay, so when the patient presents with urethral discharge, there can be two specific lesion types, that is gonococcal urethritis, which can cause urethral discharge, or non-gonococcal urethritis. So it can be gonococcal or it can be non-gonococcal. Gonococcal, all of you know, is due to Neisseria gonorrhoeae. So Neisseria gonorrhoeae causes gonococcal urethritis, while non-gonococcal urethritis is caused by Chlamydia trachomatis. Among non-gonococcal, this is the most common causative agent. Other causative agents are Ureaplasma ureolyticum. It can be due to Trichomonas or Mycoplasma. Now, how these patient presents, the incubation period here is short, 2 to 5 days, while here it is prolonged, 7 to 14 days. The presentation, as you all know, is urethral discharge, and you need to examine this discharge. You will find it is profuse and purulent in cases of gonococcal urethritis, while it is mucoid and scanty in cases of non-gonococcal urethritis. To confirm your diagnosis, you can do investigation. So you can take this urethral discharge swab and go for gram staining. On gram staining, you will get this gram negative diplococci in polymorphonuclear cells, that is neutrophils. So within neutrophils, you will get these diplococci, while another investigation, which is the investigation of choice or gold standard in these cases of gonococcal urethritis, and that is culture. So culture can be done, and remember, the media which is used is Thayer-Martin. So Thayer-Martin media is used, while here you can do nucleic acid amplification test. So nucleic acid amplification test is done. Next is treatment. In cases of gonococcal urethritis, dual therapy is given. This dual therapy is in the form of injection ceftriaxone 250 mg stat, and tablet azithromycin 1 gram stat. So according to CDC, these are the doses of these two drugs which are given simultaneously, that is injection ceftriaxone 250 mg and 1 gram of azithromycin. But in recent edition of Rooks, if you look at these doses, there it is mentioned 500 mg of ceftriaxone and 2 gram of azithromycin. So either of these doses will be mentioned, either this will be mentioned or this will be mentioned, but if both are mentioned in separate option, then choose 500 ceftriaxone and 2 gram azithromycin. Now as you can see, there is one injectable drug here, okay, and if the patient is not willing for taking injection, or the question comes that which is the oral treatment for this condition, okay, so if oral treatment is asked, the oral drug or the substitute for ceftriaxone is oral cefixime. So this is not the first choice, but if ceftriaxone cannot be given, then cefixime can be used, 400 mg stat. This is oral drug. Now if we talk about non-gonococcal urethritis, here the treatment is azithromycin 1 gram stat or doxycycline 100 mg BD for 7 days. So doxycycline 100 mg BD or azithromycin 1 gram stat. Let us see few images from this group which we have just now discussed. Now there is a condition which is known as PPP, pearly penile papule, and in this condition you will find these soft outgrowths at the coronal sulcus of penis. And this is a very distressing condition for the teenagers, because during the time of, initially they were not present, but during the time of puberty these lesions develop. But remember that these are benign lesions, also known as histoid papilloma. So this penile pearly papules, these are the benign lesions and they might develop during teenage or during adolescence, during puberty, and these are normal lesions and these are not a form of STI. So sometimes this option is there in the question. So remember, these are not STI and these are not any STI like viral warts. These are not viral warts. These are not growths of due to warts. These are actually benign growths which might develop at the time of puberty around the coronal sulcus. Now this ulcer which is present is syphilitic ulcer. As you can see, the clues here are single. So single genital ulcer is present, and if you palpate you will find these will be very hard, firm base, so hard chancre, and these are painless. Okay, so these clues if they are present, and the lymph node will be, yes, rubbery lymphadenopathy. Then another ulcer, you can see single, and you can see this is present near frenulum. Then sometimes, see, genital ulcers are generally seen, but sometimes a patient might present with oral lesions. Okay, so oral ulcer of syphilis might also be present. This is comparatively rare, but this is also a presentation. Then the investigation of choice I told you is dark ground microscopy. So when you take the smear from this genital ulcer of syphilis and see it under microscope, you will find this Treponema pallidum which have this corkscrew movement. Then in females you might get these genital ulcers. These are also, you will find painless, single, and on palpation they are very firm, so firmly indurated genital ulcers of syphilis. Here again you can do the same thing. You can take the smear and see it under dark ground microscopy. You will find these Treponema pallidum having spiral shape and corkscrew movement. Then secondary syphilis, I told you, can present with various type of lesions except for vesicobullous lesions. Over palm and sole, they are generally these pigmented lesions which are present, and if you take head end of the Alpin and press them, you will find these lesions of secondary syphilis over palm and sole. They have deep dermal tenderness. Then secondary syphilis have various presentation, like I told you, one of the differential diagnosis for secondary syphilis is pityriasis rosea, because pityriasis rosea also present with erythematous scaly lesions over trunk. So you can see these erythematous scaly lesions over trunk. So many a times we get confused with pityriasis rosea. Okay, and you can see the scaling which is present here at the periphery. Similarly, peripheral scaling is seen in the lesions of pityriasis rosea also. Here again you can see scaly lesion. So sometimes scaly lesions are also seen. These are known as psoriasiform lesions of secondary syphilis. Now I told you highly infectious lesions of secondary syphilis are condyloma lata, and lata means broad. So these are slightly broad lesions. They are not pointed lesions, and these lesions are generally present where they are present over the wet areas or the moist areas like groin or perianal area. Then I told you the non-scarring type of alopecia which is seen in secondary syphilis is moth-eaten alopecia. So moth-eaten alopecia is characteristically seen in secondary syphilis. You can see there is semi-bardolence at places, and these irregularly thinned patches of these hair follicles might be present which are scattered all over the scalp. Then secondary syphilis can mimic so many conditions. I told you different types of lesions can be seen. So here again you can see thick scaling is present. So these are again psoriasiform lesions of secondary syphilis. Then gummatous lesions are seen in tertiary syphilis. So these are the lesions of tertiary syphilis. These are gummatous lesions. These are rubbery nodules which develop, and these may ulcerate, and when they ulcerate you will find punched out. So you can see these punched out edges with washed leather base. Then tertiary syphilis can involve mucosa also, like here you can see these rubbery nodules which are present, or gummatous lesions present over tongue. Then Tabes dorsalis is the feature of neurosyphilis. I told you these patients may have gait abnormality. Then congenital syphilis can present with Hutchinson teeth. You can see these barrel or peg shaped central upper incisors with notch. Then remember that when we give benzathine penicillin to the patient, okay, so the drug of choice is benzathine penicillin, and when we give benzathine penicillin to the patient, sometimes what happens, we need to monitor the patient for 24 hours. Why? Because sometimes they might develop this reaction, that is Xerix hexamer reaction. And why this reaction develops? Because when we give penicillin injection to the patient, there is lesses of this bacteria, Treponema pallidum, and due to which the cytokines are released, and these cytokine mediators, they might lead to this febrile reaction, and that's why you should always monitor the patient for 24 hours. So this is acute febrile reaction which is mediated by the cytokine, which is initiated by the lesses of the bacteria, and this might be seen in many patients within 24 hours of commencing the treatment. So always monitor the patient for 24 hours, and they might present with Xerix hexamer reaction. Then LGV, I told you, they generally present with unilateral tendal lymphadenopathy, and sometimes lymph nodes are enlarged on both the sides, and when they are enlarged on both the sides you might find a groove in between. So groove sign is seen. Then on investigation, I told you, you can do nucleic acid amplification test, and in histology you might get these inclusion bodies. So this chlamydia inclusion bodies might be present in LGV. Then chancroid, I told you, they present with multiple painful genital ulcers with undermined edges. So multiple, so not single, multiple genital ulcers are present. Okay, so multiple genital ulcers are present with undermined edges, and they are painful. Now here also you might get inguinal lymph nodes, and they are also generally unilateral, but they are tender. So unilateral tender lymphadenopathy might be present, and many a times they might rupture. Okay, so these are buboes, these are suppurative lymph nodes, and they might rupture. So this is sometimes might be the presentation, and you can see here also undermined edges are present. So undermined edges are present. Okay, so this is the characteristic feature. And you know chancroid is caused by Haemophilus ducreyi, which is a gram-negative cocci, and they might be present in parallel rows. So these parallel rows might be seen. Here again you can see this parallel row. So this parallel row give characteristic school of fish appearance or railroad track appearance. Then donovenosis, we discussed, it generally present with single, painless, but the base is very characteristic. If you look at the base, so if you look at the base of this genital ulcer or the base of this genital ulcer, yes, you can see it is beefy red, very granulomatous, and if you touch it starts bleeding. Okay, so this is the characteristic finding which is seen. And if you look at the lymph nodes, if you look at the inguinal areas, you won't find any lymphadenopathy. Instead, sometimes swellings might be present which are known as pseudobuboes. So there might be swellings which are present in the inguinal area which might mimic lymph nodes, but these are not lymph nodes, these are subcutaneous nodules. So these are known as pseudobuboes. So pseudobuboes is the characteristic feature which is seen in donovenosis. Again, I told you in donovenosis, donovan bodies are seen, and these donovan bodies, they have bipolar staining. So they appear something like this. They have bipolar staining. Okay, so close safety pin appearance is seen. Then I told you that there is viral STIs also. Viral STIs like herpes genitalis, In herpes genitalis, I already told you, you will find grouped painful vesicles. Vesicles are fluid filled lesions. So you will get grouped painful vesicles. So initially these fluid filled lesions are present, but many a times they might rupture, and when they rupture they form erosions. So you can see one erosion is present here, one is present here, one here, one here. So all of them are grouped together in one small area. So you will get grouped painful vesicles or erosions. Similarly here you can see these grouped lesions. Okay. Now sometimes what happens, if all these are present very closely, they might rupture, and when they rupture they might merge together to form polycyclic erosion. So you might get polycyclic erosions in genital herpes. Similarly, I told you genital wart or anogenital warts, they are also what? They are also sexually transmitted infection, also known as condyloma acuminata. So they can become sometimes very large, and when they become very large we call them Buschke-Lowenstein tumor. Like here in this case, these are the lesions of Buschke-Lowenstein tumor, and if they are very large, we might need surgical removal, that is we can do cure it. Then another viral STI is genital molluscum contagiosum, and whenever you get these pink pearly dome shaped papules in genital areas, what you should look for? So whenever you examine these lesions, always look for central depression, central umbilication. So with central umbilication, this will help you reach the diagnosis. So all lesions, they have central umbilication. So if you find such lesions over genital areas, then it is genital molluscum contagiosum. And which is the investigation which is done? You should always look for, on histology, Henderson-Patterson body. So intracytoplasmic eosinophilic pink inclusion bodies are seen. These are known as Henderson-Patterson bodies. Now I told you these patients can present with urethral discharge as well. So urethral discharge, the only complaint of the patient is urethral discharge. And if you look at this urethral discharge, you can, if the patient is not having profuse urethral discharge, or if you are unable to see and if you want to take the specimen, what you can do, you can milk the urethra, you can press it from the behind, and as you move forward, what you will find this urethral discharge coming out. And as you can see here, this urethral discharge is pus colored, isn't it? Yellowish in color, purulent, and in large quantity it is coming out, so profuse. And whenever you get profuse purulent discharge, this is suggestive of gonorrhea. So this is gonococcal urethritis. Sometimes patient can present with vaginal discharge also. This gonococcal urethritis generally in female patient is asymptomatic, but there might be vaginal discharge present. And you know, this is in gonorrhea generally this vaginal discharge is absent in females. It is asymptomatic in females, but vaginal discharge have other common causes. Like I told you, vaginal discharge patients are generally due to vaginal candidiasis. So it can be due to candidiasis, trichomoniasis, and bacterial vaginosis. So these are more common causes of vaginal discharge. Now whenever there is chlamydial infection, like if the patient is suffering from chlamydial infection, then you will get, so in a female patient, if you take this cervical smear, you will get these chlamydial inclusions. Now this is the syndromic management of these various sexually transmitted infection. Okay, so I told you there are various syndromes, and in these various syndromes there are various drugs which are used. Okay, so the font is very small, but need not worry, I am going to tell you each and everything. So remember that there are 7 syndromes depending on the presentation of the patient. Like patient can present with urethral discharge, anorectal or cervical discharge. So if the patient is having urethral, anorectal and cervical discharge, then this is syndrome 1. If the patient is having vaginal discharge, then it is syndrome 2. If the patient is having genital ulcer, then it is syndrome 3. Remember, genital ulcer which are non-herpetic. Then 4th, if the genital ulcer is present and the patient is allergic to penicillin, we group it under 4th syndrome. Then 5th is genital ulcers which are herpetic. Then 6th is lower abdominal pain, and 7th is inguinal buboes. Now let us try to understand this. Okay, now patient presents with urethral discharge. I already told you there are 2 common causes of urethral discharge. It can be gonococcal or it can be non-gonococcal. Okay. Now for gonococcal, what is the drug of choice? I told you ideally you should give injection ceftriaxone and azithromycin. Dual therapy is given, but because this is STI and this is these are the kits which are available, and injection many a times under supervision you have to give. So what happens, many a times injections cannot be given easily at the peripheral health centers, so oral drug is preferred. And which is the preferred oral drug for gonococcal urethritis? I told you it is cefixime. So for gonococcal you need to give cefixime, and for non-gonococcal I told you can give azithromycin or doxycycline, and because doxycycline is contraindicated in pregnant patient, we prefer azithromycin. So azithromycin for then this STI. So if you give cefixime and azithromycin simultaneously, it will take care of all the two conditions, that is gonococcal as well as non-gonococcal urethritis. And that is the reason why in this kit 1, which is grey in color, which is used for urethral, cervical and anorectal syndrome, have azithromycin 1 gram and cefixime 400 mg. We give both these drugs simultaneously, and this take care of both the things, that is gonococcal and non-gonococcal urethritis, and that's why this is the syndromic management of urethral discharge. So patient comes with urethral discharge, simply give kit 1 which is grey in color. Okay, simple. Now come to vaginal discharge. This also we have already discussed. It can be due to, so vaginal discharge can be due to candidiasis, trichomoniasis, bacterial vaginosis. For candidiasis we give fluconazole. For these two, both these they respond to secnetazole. So secnetazole 2 gram, fluconazole 150 mg. Both these drugs are present in kit 2, which is green in color. So green kit is used for second syndrome, which is vaginal discharge syndrome. Now come to third, and third one is genital ulcer. Now when the patient comes with genital ulcer, always remember that at least look for vesicles, that is the fluid filled lesions. So when the patient comes with genital ulcers, look for vesicles. Now if vesicles are absent or if vesicles are present, the diagnosis can be different. Like vesicles are very characteristically seen in herpes. So if vesicles are present, it is probably herpes. And in herpes, the drug of choice is acyclovir. So if this genital ulcer is herpetic, that is it is having vesicles, we give kit 5 which is red in color, which have acyclovir 400 mg 3 times a day for 7 days. Okay, so this red kit is used for herpetic genital ulcer disease or genital ulcer syndrome. Okay, this is kit 5 red in color. Now what about if the vesicles are absent? If the vesicles are absent, then probably this is syphilis. So probably this is syphilis, or it can be chancroid. Now it can be syphilitic ulcer or chancroid ulcer. Now if you remember all the features and if you have lab facilities available, you can specifically diagnose whether this is syphilis or whether this is chancroid. But if you don't have lab facilities available and you are at a peripheral health center, what do you need to give? You need to give syndromic management. So for syphilis, what is the drug of choice? Penicillin. And for chancroid, what is the drug of choice? It is azithromycin. And that is the reason why for genital ulcer, which is non-herpetic, that is without vesicles, where we need to treat for syphilis and chancroid, we give kit 3 which is white in color, which have penicillin. So benzathine penicillin injection 2.4 million unit and azithromycin 1 gram. So penicillin will take care of the syphilis and azithromycin will take care of the chancroid. Okay, but remember that before giving penicillin injection, you need to do sensitivity testing, and if the patient comes out sensitive to penicillin, you cannot use penicillin, and then we use kit 4. So if the genital ulcer disease is there, which is non-herpetic, that is which is not having vesicles, but the patient is allergic to penicillin, then we use doxycycline and azithromycin. Doxycycline 100 mg BD for 14 days and azithromycin 1 gram stat. This is kit 4 which is blue in color. Okay, so this is kit 4 which is blue in color, and red I already told you if it is herpes, that is acyclovir. Now sometimes patient present with inguinal buboes, that is lymph nodes. Okay, so enlarged inguinal buboes or lymphadenopathy. Now the patients of lymphadenopathy are generally seen in, so the presentation can be lymphadenopathy in a case of LGV, isn't it? And similarly chancroid can also present with lymphadenopathy or inguinal buboes. Okay, so in LGV, what is the drug of choice? It is doxycycline. And for chancroid, what is the drug of choice? It is azithromycin. So this kit, which is used for inguinal bubo syndrome, have doxycycline 100 mg BD for 21 days and azithromycin 1 gram stat. And this is kit 6 black, which is used for inguinal bubo syndromes, which can take care of both LGV as well as chancroid. Okay. Now, sometimes patients present with lower abdominal pain, that is pelvic inflammatory disease, and one of the cause of pelvic inflammatory disease is anaerobes. So we need to tackle anaerobes also. So here it contains not only cefixime, which take care of the gonococcal infection, and doxycycline, which take care of the non-gonococcal infection, but along with this there is metronidazole also, which take care of the anaerobes. And that's why this is the combination which is used in kit 6, which is yellow in color, and it is used for lower abdominal pain. Okay, so these are various kits, their number, their color coding, and the various drugs which are used. Okay, so again we are going to quickly revise. So if the patient comes with urethral discharge, you need to take care of gonococcal and non-gonococcal, and that's why we give azithromycin and cefixime, and this is kit 1 gray in color. So simply if the patient comes with urethral discharge, pick gray kit and give it to the patient. It will take care of both the things, gonococcal as well as non-gonococcal. Second is vaginal discharge, which can be due to candidiasis, trichomoniasis, and bacterial vaginosis. For candidiasis, fluconazole. For these two, we give secnidazole. Both these drugs are present in kit 2, which is green in color. This is used for vaginal discharge syndrome. Now, if the patient present with genital ulcer, at least look for vesicles. If the vesicles are present, that is suggestive of herpes, and then we give genital ulcer syndromic management for herpetic ulcer. That is acyclovir 400 mg 3 times a day, which is present in kit 5, which is red in color. But if the vesicles are absent, it can be due to syphilis or it can be due to chancroid. So both these drugs are present in kit 3, which is white in color. So white kit is used for non-herpetic genital ulcer like syphilis and chancroid. But remember that patient can be sensitive to penicillin. So if the patient is allergic to penicillin, what you can do, you can give next kit, which is blue in color, which instead of penicillin have doxycycline along with azithromycin. If the patient comes with lower abdominal pain or the pelvic inflammatory disease where there is a role of anaerobes, so we need to give metronidazole, which is present along with cefixime and doxycycline in kit 6, which is yellow in color. And the last one is inguinal bubo syndrome, where we need to treat for LGV and chancroid, so we give doxycycline and azithromycin in the form of kit 7, which is black in color. Now remember, for lower abdominal pain, the doses are cefixime 400 mg 1 tablet, metronidazole 400 mg BD for 14 days, and doxycycline 100 mg BD for 14 days. Okay.